Welcome to the deep dive. Today, we're taking a plunge into something quite remarkable: hyperbaric oxygen therapy, or HBOT. Our mission: to really unpack a systematic review looking at how HBOT fares against the really tough, late complications that can follow head and neck cancer radiation treatment. We've got 17 studies, over 600 patients involved.
And it's a critical area. Head and neck cancer is unfortunately pretty common, the seventh most frequent globally. Radiotherapy is often essential, but it carries this risk of what we call late radiation tissue toxicity injuries, LRTTI.
LRTTI. That sounds serious.
It is. Things like osteoradionecrosis, ORN, where bone tissue literally dies, or severe dental problems, chronic dry mouth, xerostomia. These happen because radiation, while killing cancer, also damages healthy tissue, causing hypoxia.
Hypoxia meaning lack of oxygen.
Exactly, oxygen starvation. This leads to blood vessel damage, scarring, fibrosis, and eventually tissue death, particularly in tissues that don't turn over quickly, like bone and muscle.
Okay, so that's the problem. And HBOT is pitched as the solution.
It's proposed as one, yeah. The concept is fascinating. You breathe 100% pure oxygen inside a pressurized chamber, typically at 2 to 3 times normal atmospheric pressure. That's 2 to 3 ATA.
High pressure pure oxygen. What does that actually do?
It dramatically increases the amount of oxygen dissolved directly into your blood plasma. We're talking PaO levels, the oxygen in arterial blood potentially hitting 2,000 millimeters of mercury.
2,000, that sounds immense compared to normal levels.
It is. It's like super oxygenating the blood, bypassing the usual limits of red blood cells.
So the idea, the physiological promise, is that this flood of oxygen can, reverse the radiation damage?
That's the hope. Short-term benefits like reducing swelling, getting more oxygen delivered immediately. But the bigger aim is long-term healing. Things like promoting neovascularization, growing new blood vessels, stimulating bone regeneration, increasing collagen, basically trying to revive those damaged tissues.
Okay, the potential sounds huge. So the core question this review tackles, what we need to explore is, does this powerful physiological effect actually lead to consistent, real-world healing for these HNC patients dealing with LRTTI?
That's precisely it. Does the science translate into clinical benefit? The review, covering studies from 2004 to 2022, gives us a really complex picture.
All right, let's dive in. What's the headline finding? The overall picture from these 17 studies?
Well, on the surface, it looks quite good. The review mentions that HBOT is generally presented in these studies as reliable, safe, and, 14 out of the 17 studies reported positive outcomes.
14 out of 17 sounds pretty convincing.
It does, but here's the absolutely crucial context, and this is vital for anyone listening, especially if you're considering this therapy. The review strongly concludes that this positive impression, it's built mostly on evidence from low-quality studies.
Low quality. How low are we talking?
We're talking 10 out of the 17 studies flagged with a high risk of bias. Many were small case series, observational studies, not the robust controlled trials you'd want. They often had tiny sample sizes, inconsistent ways of measuring results.
So the foundation is shaky.
Very shaky. The review authors are explicit. We need more high-quality research before clear clinical guidelines can be made. That positive count, it's potentially misleading.
That really changes the perspective. Okay, before we get into specifics like ORN, what about safety? Putting someone under pressure with pure oxygen, are there significant risks?
The overall incidence of side effects reported was low, but they definitely exist. Things like reversible vision changes, myopia, were fairly common, sometimes temporary shortness of breath, or subcutaneous emphysema, which is air trapped under the skin.
Annoying, but maybe manageable. Anything more serious?
Yes, though rarer. Pulmonary oxygen toxicity is a known risk. There were also very rare but severe events noted, like seizures, though these were often linked to other issues like brain metastases. And tragically, some deaths occurred, but they were attributed to the cancer coming back or other major events like a carotid artery rupture, not directly the HBOT itself in most cases reviewed.
So not risk-free, but generally considered acceptable given the underlying condition.
That seems to be the consensus in these studies, yes. Tolerated reasonably well by most.
Okay, let's get into the specific complications. Osteoradionecrosis, ORN, the dying jawbone. This sounds like one of the worst. How did HBOT fare here?
This is where HBOT has probably been studied the most, and almost all those studies reported some kind of benefit. 3 even found statistically significant improvements, but, and it's a big but, when you look closely at the better quality trials, the picture gets muddy, really muddy.
How so? Give me an example.
Okay, so for treating ORN that's already developed, one study compared surgery plus HBOT versus surgery alone. After a year, the HBOT group had a 70% healing rate versus 51% for surgery only.
70% sounds much better. That's nearly a 20-point difference.
It sounds better, absolutely. But the difference wasn't statistically significant. The p-value was 0.13.
Ah, the sample size issue you mentioned earlier. Not enough patients to be sure it wasn't just chance.
Exactly. A potentially meaningful clinical difference, but the study lacked the statistical power to prove it definitively.
Frustrating. What else?
Well, then you have another large randomized trial, N. et al., which found the opposite trend. The HBOT group actually had lower recovery rates, 19.3% compared to the placebo group, which saw 32.4% recovery.
Wait, the placebo group did better. How does that happen?
It's counterintuitive, isn't it? Again, the difference wasn't statistically significant, but it certainly raises questions. The review authors suggest maybe differences in the patients themselves at the start, or the severity of their ORAN weren't fully accounted for. It highlights the control issues.
So treating established ORAN is confusing. What about using HBOT to prevent it, say, before a risky dental extraction in an irradiated jaw?
Similar story, mixed results. There was a big trial called HBOT specifically looking at prevention. It found basically no difference in ORAN rates between the group getting HBT and the group that didn't. It was about 6.4% versus 5.7%. Very close.
Not very encouraging for prevention, then.
But then another smaller study looked just at using HBOT prophylactically before tooth extractions. And in that specific context, they reported excellent healing for 53 out of 54 extracted teeth. Just one complication.
So maybe it's beneficial for preventing problems after minor procedures like extractions, but perhaps not as a general preventative strategy.
That could be one interpretation, yeah. The specificity might matter a lot.
Okay, so ORAN is complex. Let's shift to something that affects daily life profoundly. Xerostomia, chronic dry mouth, and general oral health after radiation. Is the evidence clearer here?
It seems to be yes. More consistently positive, I'd say. Dry mouth is just miserable. Impacts eating, speaking, everything. One study, Kankar et al., found a statistically significant improvement. The xerostomia grade dropped quite a bit, from 2.63 down to 1.94. That's a real change. And salivary flow actually increased.
Sounds promising. Any other supporting evidence?
Another group, Tagu et al., looked at patient-reported symptoms, what people actually feel. They found significant improvements with HBOT for specific complaints like sticky saliva, that overall feeling of a dry mouth, and even difficulty swallowing. The p-values there were quite strong.
That's important, linking it to what the patient experiences. I also saw something interesting about bacteria.
Yes, that was fascinating. The Kankar study also observed significant decreases in the levels of certain bacteria in the saliva after HBOT, specifically Streptococcus mutans and Lactobacillus, which are often linked to cavities.
So it might actually be improving the oral microbiome, too. That could have huge long-term benefits for dental health.
Potentially, yes. It suggests multiple pathways of benefit, though, again, it's not a slam dunk across the board. One study looked at dental implant survival in irradiated jaws. They found no significant difference in success rates between patients who got HBOT and those who didn't. About 85% survival with HBOT versus nearly 94% without.
So maybe it helps the gums and saliva, but not necessarily the bone integrating with an implant.
That seems to be what that particular study suggests. The complexity continues.
Which brings us back to the underlying mechanism. We know the oxygen levels go way up. Is there solid proof the oxygen is actually getting to the damaged tissues and making physical changes?
Yes, and this is probably the most compelling part of the evidence, the physiological proof. It shows the principle works. One study, Smalastad et al., actually measured blood vessel density in tissue samples after HBOT. Significant increases in both blood vessel density and lymphatic vessel density.
So literally building new plumbing in the tissue.
That's a great way to put it. Real measurable neovascularization. Another study, Thorne et al., measured oxygen levels directly in the irradiated gum tissue. Before HBOT, it was only at about 50% of normal levels. After 30 HBOT sessions, it jumped to 86%.
A massive improvement in tissue oxygenation.
And one more, Vidmar et al. Used MRI scans to look at the parotid gland, the saliva gland. They found significant changes after HBOT, suggesting improved glandular function or at least structural changes. So the physiological effects, they seem pretty robust and well documented.
Okay, that's critical. The oxygen is getting there, it is promoting vessel growth, but somehow this clear physiological win doesn't always translate into clear clinical wins, which leads us perfectly into the next section, pain and quality of life. This is where the data seems to clash the most, right?
Absolutely. The findings on pain are Well, almost contradictory depending on the study you read. That Tegu study we mentioned earlier, it reported a highly significant reduction in pain scores in the mouth for the HBOT group. A p-value less than 0.0001 looks fantastic.
You can't ask for much better statistical significance than that.
You really can't. But then you look at the HBOT trial again, it reported only minor improvements in pain, and they weren't considered clinically significant. And remember that a main trial where the placebo group did numerically better for aura and healing?
Yeah.
They also found no significant difference in how long it took for pain relief between the HBOT group and the placebo group. The p-value was 0.99, basically no difference detected.
Wow. So massive pain relief in one study, virtually none in others.
Yeah.
If the tissue is getting more oxygen and new blood vessels, why wouldn't pain consistently improve?
That is the puzzle. It could be that the pain mechanisms involved are more complex than just hypoxia. Maybe nerve damage plays a bigger role that HBOT doesn't address as effectively. Or perhaps more likely, it comes back to the inconsistencies in the studies themselves, who they included, how severe the pain was initially, the exact HBOT protocol used. It clouds the picture.
Okay, and quality of life. Does that show a clearer benefit?
Unfortunately, no. Also very mixed. Tegu et al. Found HBOT reduced some late side effects, which you'd think would improve QOL, but they didn't find significant QOL differences overall during the main study period.
And any negative signals?
Well, Schoen et al., who looked at the dental implants, also used standard QOL questionnaires. They found no significant improvement in general QOL scales after HBOT. And weirdly, they actually found that emotional functioning significantly improved in the control group, the ones who didn't get HBOT.
That's baffling. The control group felt emotionally better. Any idea why?
The review doesn't offer a firm explanation, but it certainly doesn't support HBOT as a major QOL booster in that context. It could be chance, or perhaps related to the burden of undergoing the lengthy HBOT treatment itself.
Right, so we've got this stark situation. Strong physiological rationale, evidence of tissue repair happening at a micro level, but then these frustratingly inconsistent or even contradictory clinical results, especially for pain and QL and the higher quality studies. Which leads us to the big why. Why is the evidence such a mess?
This is really the crux of the review's conclusion. The limitations are substantial. The first massive issue is what they call clinical heterogeneity. Basically, the studies were all over the place in how they did the HBOT.
You mean like different pressures, different numbers of sessions?
Exactly. Pressures ranged from 2.4 to 2.8 ATA, the number of sessions, anywhere from just 8 dives up to 115. That's a huge difference. And it often wasn't even clear if they were using it to prevent a problem before it started or to treat damage that was already there.
It's like comparing apples and oranges.
Yeah.
Or maybe apples and watermelons. You can't pool that data meaningfully.
Precisely. It makes any kind of meta-analysis incredibly difficult, if not impossible. Then there's the study design problem we touched on. So many were low-quality observational studies or case series. These are useful for generating ideas, but prone to bias and often lack proper comparison groups. They tend to get published more easily if they show positive results, creating a bias in the literature.
And measuring success was also inconsistent.
Hugely. Some used pain scales like VAS. Others used specific clinical scores for ORN, like the Notani score. Others used different quality of life questionnaires. If everyone's measuring success differently, how can you compare the outcomes across studies?
It seems obvious we need standardization there.
Desperately. And finally, confounding factors. Cancer treatment is complex. Did the patient also have chemo? What was their total radiation dose? Did they have diabetes, which affects healing? Were there differences in the surgery performed alongside HBOT? Many studies didn't adequately control for these other factors that could influence the outcome, making it hard to isolate the specific effect of the HBOT itself.
Okay, so putting it all together after this deep dive,
Yeah.
What's the final message? What should someone take away about HBOT for these H&C complications?
I think the message is one of cautious or tempered optimism. HBOT clearly has a strong physiological basis. It demonstrably improves tissue oxygenation and vascularity, and there are definite signals of benefit for some outcomes like xerostomia and perhaps certain aspects of ORN management. But the current clinical evidence just isn't strong enough to make definitive recommendations. It's hampered by all those limitations. Low quality studies, massive variation in protocols, inconsistent measurements. We urgently need large, well-designed, randomized controlled trials with agreed-upon, standardized protocols and long-term follow-up.
So the potential is there, the science makes sense, but the clinical proof, especially from rigorous trials, is lagging behind or inconsistent.
Exactly. We need to bridge that gap before this can become a standard, widely adopted treatment with clear guidelines on who benefits most and exactly how it should be given.
All right, so let me leave you, the listener, with a final thought to consider. We've established HBOT has these really potent physiological effects, boosting plasma oxygen to incredible levels, demonstrably increasing blood vessels and damaged tissue. Given that power and the often devastating nature of these radiation injuries, what level of clinical improvement should we deem worth it? If a future high-quality trial shows, say, a consistent but modest 15% or 20% improvement in swallowing function, or a similar reduction in chronic pain, not a cure, but a definite measurable gain, is that clinically meaningful enough to justify the significant time, effort, and cost of potentially 30, 40, or more HBOT sessions, especially if patients themselves report feeling subjectively better?
It really forces you to weigh statistical significance against what truly matters to the patient's daily life. A really tough question.
Something to ponder. Thanks for joining us for the deep dive. We'll catch you next time.